Good afternoon. Good morning. It's good to see you all. My name is Kyle Strickland. I'm with the Kerwin Institute of Study of Race and Ethnicity, the manager for strategic partnerships and community engagement. And I'm very excited to welcome you to the Kerwin Fall Forum Series. We kicked off the Forum Series back in 2017, 2018 or so. Obviously had a bit of a pause during the pandemic, but had a virtual forum series that we had many of you joining us in person and online as we moved to that hybrid stage. So I do want to welcome those of you who have joined us online. We got this fancy owl set up here that is recording us as well as recording the presentation. I also want to welcome you all for joining us today as part of this forum series. We're so excited to kick off this series. And who other than our very own here at the Kerwin Institute, in addition to Adreana, which I'm going to introduce. I'm going to provide their introduction. They're going to kick us off. We're going to have time, of course. If you need to grab food, feel free to grab some food. There's some waters. If you need to use the restrooms, they're all the way in the back and then to the right, and then they'll be on your left. And just let us know. We've got Heidi and Macy here, and then Emily up front to help support. But without further ado, I want to introduce Adreana Tartt with the Ohio Department of Mental Health and Addiction Services, Mikyung Baek, and Glennon Sweeney with the Kerwin Institute of Study of Race and Ethnicity. Give them a hand. All right.
Thanks to all, and congratulations to Kerwin Institute on their 20th anniversary. I am so thankful to have them in our community in Ohio. Let's give Kerwin's team a good hand. So I wanted to, and I also wanted to kind of share, thank you for joining us today, as well as some of our partners that are in the audience, in person and online, that have been participating with us. So I wanted to just kind of give just a brief introduction. You want to help me click, Glennon?
Here, we're just going to click it on this page and then it'll start.
Okay, right now. Okay. I wanted to just kind of start talking about relationships that we have with one another, with our organizations, within our community, and with our partners. And I wanted to just kind of share how I actually started to work with Kerwin around this particular project. I met Glennon, actually the senior researcher, in a community forum, and it was talking about Medicaid. And Kerwin has a breadth of experience in social justice, and Glennon was sharing some of the information that really kind of highlighted how certain communities that have not been privileged navigated into our systems, and really weren't equitable in terms of being able to access certain types of services and supports and so forth. And in this policy conversation we were having, there was a lot of discussion about our older adult systems and some of our long-term care systems not being able to really be able to keep Medicaid going. That at some point in time, we were going to have to make some cuts and reshape the Medicaid that we know today. And, that really kind of sparked my antennas up. And I ran into some of the previous work that Kerwin was involved in their previous research studies, and began to read some of those studies. And it was just fabulous kinds of information. It was specific to Franklin County, but it was wonderful information in terms of how we support our older African-American adults and the vulnerability that those older African Americans have because of how we came through the society. So if we look at the Civil Rights Act, that was during my lifetime. So a lot of our aging communities did not have benefits, like we weren't engaged into Social Security and so forth. A lot of folks were domestic workers. So in terms of how they would live today would be a problem. And so it really kind of got me to thinking about these older adults and how they live. And we're living in a time of longevity now. And what our resources look like in our communities. And so I approached Glennon to see if she would do a similar study statewide. And let's look at where our older African-American adults are and what kinds of resources are they connected with and so forth and so on. And it's just really been fabulous to work with Kerwin. And I'm going to just kind of refer to a little bit to some of the guiding principles that were in one of the previous studies, just to give you an example of what I'm referring to. So these were some of the guiding principles, and I'm not going to go through all of them, but I did want to highlight the first two: promote independence, not isolation, and valuing older adults and assets. With the promote independence and isolation, within the study, it highlighted making investments that help seniors age where they want to age and not do so in the context, and to do so in the context of supportive community is as equally as important as investing in aging in place. So we kind of throw that language out of aging in place, but really there needs to be, when we talk about culture, we're talking about community. We're talking about support in that living space. And that is a very valuable principle, and I think we need to keep that in mind as we look at aging in African American communities. And some of the ways that we go about that is aligning with our trusted allies and our trusted organizations with those particular cultural communities. So culture is a foundation, and those other supports and resources and services kind of align within those cultures. And so that's one of the main assets that I think is very important as we kind of move forward in the work. I think finding those advocates like faith leadership that can kind of be a part of decision-making conversations. I think that's another part that we need to really be thinking about when we're talking about African American vulnerable older adults. And faith leaders have traditionally held that role, to be in the legislatures, making those appeals, other advocates that exist in the community, other organizations. Those are pieces that we really need to kind of hone into. And I think engaging into projects that are culturally responsive. And so really engaging the community as a whole and inviting community into the work so that our work doesn't look like an organization only, but we are inviting the entire community into the work. And with that, we are being very culturally responsive and being present. We are starting to develop those relationships with those individuals we serve because their voices matter, and you have to drive it according to the person's needs, because we do practice person-centered approaches. Every individual is going to be unique within themselves. And so we want to hear those voices and those unique needs. So those are just some of the highlights that I wanted to reflect in terms of the promoting independence and not isolation, because we are in a climate in this country where we're battling social isolation and loneliness. And we've got to get into the community, we've got to get focused on what's happening in those communities and provide a very supportive atmosphere and be able to reach in to those living situations. And I think the other area I wanted to just talk about was that valuing seniors and assets that came out of the previous study, where older adults are to be seen, valued, and respected. One of the things that I experienced as my mother back in, I was a caregiver for my mother for about 15 years, but back in around 2015, when she really started to decline, I started to look around me more to see older persons in the community that were struggling just like my mom with mobility and other things. And I noticed that really we don't pay a lot of attention to older persons. In our systems, we really don't, it's like an afterthought. It's not really, they're not a priority audience. And so any way we can celebrate older persons, that is a wonderful thing for the society, and especially in the African American tradition. I looked at some of the projects that Canada was doing, and they celebrate their older persons in their systems broadly. So you may be on a ride a bus downtown to work, and there's pictures of their older persons up on in the bus with little snippets about who those persons were. And so, you know, trying to engage older adults in our everyday living environment is very important. So doing ageism kind of campaigns and dignity and respect promotional programming and intergenerational programming. I find that connecting youth or younger audiences with older adults are of value both ways. It really is a evidence-based programming now. And so I think just having a lot of those kinds of offerings. But I just wanted to just say to Kerwin how much I appreciate this research. There's going to be a second phase to it. But I'm so impressed by this research. And when I began this process, I didn't really know where to look, because within our systems, there's generally a provider or an entity that controls the research data, or they'll have something, they'll be the guru of the older adult research projects and programs. And when I approached a particular entity around, what are you seeing about older adults, African American older adults that are vulnerable? their response was that you can't really capture that small of a data set globally. So if I looked at their maps and a lot of the things that they were saying, there wasn't a way to really put your hands around what's happening to the African-American vulnerable older adults. So when I met Kerwin and they kind of did the research, it flushed it out. And so it is a wonderful opportunity to be at Kerwin. And I thank you all for kind of riding this journey with me and the department. So thank you very much. So I'm going to bring up Mikyung now to kind of get started. And why she's doing that, when my mom passed in 2018, I shared this vision with her about how important it is to bring more African-American older adults to more of a visibility. And she produced this little postcard picture book, and I'm going to just share this with you all. I'm going to pass it around. But it says timeless expressions of our eldest elders, honoring the joy of aging by celebrating the faces of our elders. So I'm going to pass this around, and she put various pictures in this postcard booklet as a way that we can share older faces and not just the younger bodies and faces, and look into the faces. And she put a couple of pictures of my mom. So I'm going to just have to do that. So thank you all for doing that today.
Yeah. You stop it there. Yeah, stop it. And then you have to reshare. You have to share the screen to like screen one. What are that? That's the screen. Do that. That's it. That's it. Because you have to go away and get see now you're sharing that. So you can do both. Yeah.
Hello, everybody. My name is Mikyung Baek. I'm Senior Research Associate here. Been here for 18 years, did a lot of mapping. So this time we did mapping of older adults vulnerability. I think we should So obviously we did, this is our third study looking at older adults. We did, we only looked at older adults in Franklin County in 2014 and 17. And this time we expanded to the entire state to look at the older adults vulnerability. So I'll talk about the spatial analysis, the quantitative part of it, and my colleague Glennon Sweeney will take over to talk about focus group and qualitative study. So what we did was we looked at the what we call older adults vulnerability indicator. This is the result of 3 rounds of review from our 3 studies for looking at older adults, and also in consultation with our study committee to look at. So these are the indicators that we picked, 8 indicators we picked as the most relevant to decide older adults vulnerability and their life outcomes or health outcomes. So starting with poverty and housing cost burden, renting, living alone, no high school diploma, with disability, with no vehicle access or lower life expectancy. That those 8 indicators tend to be relevant to make older adults more vulnerable. Notice these 8 indicators are all interconnected with each other. They are affecting each other, which I will come back later on. So based on these 8 indicators, we mapped the entire state of Ohio at census tract level. Census tract, by the way, is smaller than zip code, and it's larger than block. So, and the map that I'll show you is so. We looked at all these 8 indicators, and then we collected the data, and we calculated what we call vulnerability index, and we will have those numbers, and we divide them into 3 groups: the lowest, moderate, and high indicator score, and we call it high vulnerability, low vulnerability, moderate vulnerability, and low vulnerability. And look at, and the map I can show you is this. So by the way, this is a mapping tool that will be available publicly. The link to this map tool will be available along with our report. So you can use to look at to where the vulnerability are concentrated, where different race and ethnic groups are concentrated. You can do a lot of things. So you can turn on and off these layers. There are a lot of layers here. So right now what I'm showing is the vulnerability map of Ohio. The area of red is the areas of high vulnerability areas. Remember those three groups, and the areas with blue are the low vulnerability groups areas. So if I zoom in a little bit, you can see how these red areas are very much concentrated in like metropolitan areas, like Cleveland, Columbus, and those areas, and also some southern part of the state. And what we also did was on top of this map, we overlaid what we call the racial groups, so that we will know which group of older adults are concentrated in terms of the different levels of vulnerability. So if I can count on one of the layers here. So this is white, and then this is African American. Notice if I zoom in a little more, you can see how this, kind of teal colored dot are more concentrated in red areas, meaning higher vulnerability areas. And when we do a analysis of all this is the result of the racial disparity in terms of the vulnerability. You can see how like 60% of African Americans are living in high vulnerability areas versus over 40% of white older adults living in low vulnerability areas. So we see across the state, we see a lot of racial disparity. And another thing we did was look at the density and prevalence of older adults. For a lot of policymakers and service providers, not only the level of vulnerability is important, but it is important to look at how much how much more of older adults are concentrated in some areas. And the density of the population is very important in metropolitan areas, but the prevalence where the population of older adults are lower, the prevalence of older adults population in the census-tract area is more relevant for if you go to the rural areas. So we did both of those maps, and you can now I can turn off the vulnerability, and then I can turn on the vulnerability and density areas. As you look in this, the legend, you can see the red color is still high vulnerability and blue color is still low vulnerability, but the darker the color is, the higher the density is. That means, you can see it, those areas in metropolitan areas have come up as darker areas, meaning there are more of older adults living in those areas. And we also did the racial and disparity analysis of vulnerability and density, and this is what we found. You can see that 41%, over 40% of African Americans live not only in high vulnerable areas, but also they are in high vulnerability and high density areas. And 16% more live in high vulnerability and moderate density areas. Compared to that, about like 20% live in whites live in low vulnerability, but also they live in low density areas. This also means that suggests that if you, plan very, if the place-based intervention is properly implemented, you can, if you look at those areas with high vulnerability and high density areas, and if you implement some of the interventions there, that means you can not only, helping older adults who are in high vulnerability, but also you are getting more like outcome in terms of the limited amount of resources, right? Yeah. And on top of the just looking at the vulnerability and density and prevalence, what we also did was we also analyzed the Medicaid data from 2019, looking at the Medicaid claims of older adults 55 or older for 10 chronic conditions that are more relevant to African American adults, like Alzheimer's, diabetes, depression, or hypertension. 10 chronic conditions. For all those list of things, you can go to our website and look at our report. And also we looked at the mental and behavioral health conditions, the ICD-10 codes, F codes. So what we did was look at the overall like case counts to look at the of this overall case counts, and we also looked at the instance rates by race and ethnicity to look at how many times that they claim Medicaid data. And another thing that we looked at was the racial disparity, meaning our African American older adults are filing for 10 chronic conditions. I mean, at more rates, higher rates than other racial groups. So what you are seeing here is when the value is positive, meaning the red color areas are the areas where African American older adults are filing more at higher rates than other racial groups. So from across the state, we found that 80% of census tract had racial disparity value of positive, meaning African American older adults are filing at more rates. And we did the same for mental and behavioral health conditions. And the last thing that I'll talk about is so you can all go to the mapping tool. For the sake of time, I'll just skip to. So remember I talked to you about all those, needs and indicators that are interconnected with each other. And we have seen that older adults are facing different types of needs with different multiple different combinations. So what we did was we looked at like areas of higher vulnerability and also areas of higher density. And we also areas of higher incidence rates of 10 chronic conditions, higher incidence rates of mental and behavioral health conditions. And lastly, we looked at where areas of the most needs for digital connectivity. What we did was we looked at the broadband connection speed, and also we looked at the percent of older adults who have computers and who are subscribing for internet. And we by looking at the intersection of supply and demand, we were able to identify the areas where there are enough African American older adults who are, willing to pay for the internet, who have access to computers, but the broadband connection is slower in their area. So those are the areas we need more like intervention in terms of investment in terms of digital connectivity, because digital connectivity was not one of our indicators that we included in our vulnerability index. It came up through our conversation with our study committee members and also the focus group. We found out that digital connectivity is very important for older adults' lives. So we looked at those 4 needs. So this is the area showing higher vulnerability, higher density areas, and this is the area of instance rates 10 chronic conditions, which is 2 or higher. That means they are more likely file at least 2 times a year for those 10 chronic conditions, and this is same for mental and behavioral conditions. And these are the areas where you need digital connectivity intervention. So when we overlap all these 4 maps each other, we can which are of these areas in the state showing up multiple times on this map, what we call multiple and complex needs. So when we look at across the state to look at which areas have the most needs, this is the map that we found. So across the state, there were like more than 40%, I believe. See my notes. Yes, 44% of OI census tract has at least 2 needs. So 40%. At least 2 needs. At least like among like vulnerability, 10 chronic conditions, multiple behavioral health conditions, or digital connectivity needs. So you can see how close to 50% of census tract are facing at least 2 needs for older adults. And And you can also look at these maps here. So these are the counts of needs. There were like 69 census tracts that had all those 4 needs covered, 4 needs identified. And you can go to this map and see how your neighborhood or the neighborhood that you are trying to make some changes to are doing. And there is a tool that you can do like search or something. You can actually type in address or place, and the map will zoom into that area. And if you click on it, it will show you which of the needs this area has. So it says for this particular census, it has 3 needs identified, like high vulnerability, low density. So this is not counted. So, but Black incidence rate for 10 chronic conditions was 32, 58 for mental and behavioral health conditions, and it had moderate growth and moderate senior access to computers. So you can see, we can navigate throughout the state to see which area is having the most needs the most. So what the map does is to kind of direct you to where to focus in terms of intervention or service areas. But what the map does not do is what the people on the ground are actually facing. So that's why focus group and talking to people on the ground is needed, and also what Adreana talked about, how the community engagement is also needed. So I'll turn it over to Glennon to talk about it. Thank you.
How's everyone doing? All right, so I'm going to talk about both our qualitative findings as well as a couple of the recommendations. And I'm just going to highlight some of the qualitative findings. So we did this study during the pandemic. We had planned 9+ focus groups, and we were planning to do a hybrid approach. Some would be virtual, some would be in person, because there was another wave of COVID that came right as we were ready to do these. Could not make the virtual focus groups work, which once we did the in-person ones, it became abundantly clear to us why that was the case. But we just could not get those to work. And we really struggled, especially with some of our smaller nonprofit partners. They just didn't have capacity to help us, to give us space, to even help recruit people in different parts of the state to hold these. Because of the impacts that the pandemic had on their organizations, their staffing and things like that. And so we ended up with 6 focus groups, which wasn't ideal. And I also want to point out, focus groups are not representative. They're not like surveys. It's not like we'll get like a representative chunk of the population and can say something significant about the entire population. Focus group findings are significant to the population you talk to, but they give good insight into what you should be looking into further. And so that's what these findings really suggest, is areas that we need to do a little bit more digging in this state, because these are the things older African Americans are saying they are experiencing. So we ended up engaging 28 individuals in August and September of 2022. They were about 90-minute focus groups. They were recorded, transcribed, and analyzed in vivo. And we identified 13 interconnected themes, 3 of which I'm going to highlight today. One that I'm not going to highlight today is about technology, though. All right, so like really challenges, and we call it like the 2 sides of technology. In every focus group, there were a couple individuals who like got it. They're on the internet, they know how to use things. They're the ones everyone else goes to figure out how to navigate things. But a lot of the older adults that we talk to really don't feel comfortable navigating the internet, might not have access to devices or even, you know, the internet itself in order to get online and feel comfortable, and perhaps require a different level of support in terms of learning those things. It was literally said, patient, we need patience. Like, you might need to explain it to me more than one time, you know? So that was definitely a barrier, and that is why we weren't able to make those virtual focus groups work, folks. Like, this is not a population that we're going to be having hop on a Zoom call with us easily if it's not assisted and facilitated. So I am going to talk about three really interconnected, but I think really important themes that came out that really tell us a lot about how older African Americans feel they're being viewed in society and treated. And I think really get to the heart of some of the stresses that they're experiencing. Uh-oh, someone took my notes. You might have them, Adreana, but it's all right. We'll see what I can remember from these focus groups. So systems and trust was one of the biggest themes that came about. It's fine, don't worry, I'm good. And so this was really, at first it came out in the context of medical providers in accessing healthcare. All right, and like it was literally in these focus groups, we were in Toledo, Cleveland, and Columbus, 2 in each city. You know, and they would literally name doctors and hospitals. Like this guy you can trust. This guy, I'm not gonna name those people to you. I will say that there are certain hospitals that were university loved in focus groups, certain ones that were like not, and that don't have good reputation. But what it really came down to was their experiences and interactions with individuals when they were accessing care. Whether they felt they were being listened to, whether they felt they were being respected, and also their history of engagement with these systems and the known history of African-American engagement with these systems, right? Tuskegee was mentioned more than once in terms of like, I don't know if I can trust those. And this is happening in the context of a pandemic where older, vulnerable adults were dying at higher rates. So we have folks in focus groups saying like, are we guinea pigs? Is that why we die at these high rates? Literally asking those questions because there's so much distrust. So that's a big barrier to well-being if you can't access a medical provider that you trust, right? And then another thing that really came out is that, you know, these folks are aware of the role of systems. They've lived in America their whole life. They understand what systems are and how they've kind of been, for lack of a better word, screwed over by them in the past, right? And it extends way beyond healthcare. This understanding of systems and just distrust for systems in this country is universal with this population that we engage. And so some of the quotes that came out that were very powerful from, and I will say I did name one because everyone liked them. But you know, but it's just one of the things that it really did to these two individuals was the disbelief, because I went and served my country. I did everything that you asked me to do. And when I get back, you say you take care of me and they don't do it. And this is in the context of VA care, right? Because that's one thing that a lot of older African-American adults do trust the VA if they're veterans. But there's some people who've had some bad experiences there. And that especially comes in when there are things that the VA doesn't cover, right? Like vision and dental. Literally parts of your head, your body that aren't covered, right, by medical coverage in parts of this country, right? And so, you know, if you only trust the VA, you don't trust anyone else, but you've got major dental issues, how are you going to get that addressed, right? If there's no way of getting that care, you're only going where you trust. And then in terms of you know, service providers, I tell you, everyone in Akron universally loves Catholic charities. I will say that. That's one they all like. I'm not going to tell you who everyone hated though. I think that would be mean, but Catholic charities in the morning, the people drop off their grandparents so that they can go inside. They do crafts, I should say crafts, I apologize, little activities with them during the day so that they can really socialize with other people. And I think agencies like that are really important. Here in Akron, we have a lot of agencies that give and help and work with seniors. So isolation was also one of the themes that came up. And one of the ways to combat it, we learned, was let us volunteer again. Older adults, you know, during the pandemic, a lot of places stopped allowing volunteers, and some places specifically wouldn't let older adults because they were worried about them being vulnerable with the pandemic. But volunteering is key for purpose for a lot of older adults, at least the folks that we talk to. And this is, you know, we talked to a number of vulnerable older adults and some more middle income older adults, and it was universal. Didn't matter if they were wealthier or if they were lower income, volunteering and engaging community is really important to this population, and they need opportunities to do that. And so organizations that give them that opportunity are really important, and they need connected to them, but through trusted sources, because they only want to trust information from sources they already trust. And there's this trust barrier. right? And so Edgar's shaking his head, he knows this. Edgar was wonderful and hosted one of our focus groups here in Columbus. So one of the other themes I want to talk about is this issue of respect. And this was just overwhelmingly, participants feel disrespected. They feel disrespected in medical, when they have interactions with medical providers, with other types of service providers, when they interact with firefighters, police, first responders, literally every interaction on a daily basis. These individuals we talked to reported feeling disrespected. And it kind of went, and, you know, well, I'll lead into that with the next one. And they also noted in particular that they really feel overlooked by policymakers and decision makers. You know, one of the women in one of the focus groups is like, look, we're one of the highest voting blocks. No politicians ever come here and try and get our votes. Why aren't they courting us as voters? We actually vote, and they don't even care enough to ask us what we think or introduce themselves to us. You know, so they just feel very overlooked. They want to say in policy decisions that impact their lives, and they don't feel like they have a voice right now. And so some of these quotes, there were some really great quotes that came out. Well, not great, devastating, but you know, it's like, excuse me, but I did go to college. I am a veteran. I consider myself intelligent. I'm well read. So I have just as much a right to voice what I'm thinking as the next person. And don't put me in a category based on the fact that I live in affordable housing. They need to see us as people, see us as their grandmother, their grandfather. They need to see us as human beings instead of a number, and not as lab rats. And that specifically is about medical providers. And it's also happening, this is in the context of COVID also, where they felt, a lot of the people we talked to, that they, you know, that they were very they were threatened, I guess would be the word, threatened by the number of older adults that were dying around them and friends they were losing. And they really felt like the medical community was not looking out for them. And I think that's the reparation. Damn the 40 acres and a mule, we ain't gonna get that. But some people got more than 40 acres and they still don't respect that. That should be the reparation, respect. Allow us as a people, from young to senior, to receive what we earn, what we put out, you know. So to me, it just comes back to respect. And then, you know, in the context of someone who was engaged and invited to policy decision-making table, she said, it's amazing how empowering it is when someone comes along and listens to what I got to say. You know what I'm saying? And it gives you a sense of importance. You know what I'm saying? You actually heard what I said and you're gonna act on what I said, right? Older adults are just like all of us, folks. Not like they're some alien, you know, group of people. These are our elders who deserve our respect. And then this all kind of leads into the ism, right? And it was about classism, but also very much racism and ageism, right? Really feeling like because they are African American, because they are older, because maybe they live in affordable housing or are on what they refer to as public insurance, Medicaid, right? That they don't get respect, that they are not viewed as full citizens. And they literally would say public insurance isn't as good as private insurance, and they don't get access to the same things. They saw a big difference in care. But it really came out in the context of feeling discriminated against across the board. And linking that to history, right? Going back to that, like, you know, and I know that healthcare providers shouldn't be trusted because of Tuskegee, right? Mentioning those historic events. And so a couple of the quotes, you know, I have found, or at least I think I found, that I don't think that doctors truly understand Black pain. And I say that because of the fact that I have had a Black doctor and white doctors and have been treated differently by them. Stop looking at us like chattel. They need to stop looking at us like that. They need to stop having that kind of perception because it just doesn't impact the seniors. And that's what's wrong with physicians now. They don't respect because they look at us like we are drug-ridden or some negative connotation, the same context they've had with us from the beginning of coming to this country. You know what I'm saying? So that view has not changed, the respect. And why can't we come in and say my pain level is at a 9? and you respect that, and then you do what's necessary. So many stories of people going to the doctor because they have legitimate pain, like, how old are you guys? I'm 40 and I got legitimate arthritis and pain. Going to the doctor for legitimate pain and being asked if they are on drugs. If they're coming because they want drugs, not because they have legitimate pain. I guarantee you, my white mother goes to the hospital because she got pain, she ain't gonna be asked that question. Not by anyone in that medical facility, right? You know, so these things were just really, and we have other really key findings that are really important. We wanted to highlight these because I think these are also things that we as individuals in this room can take a role in addressing. We can be more respectful. We can help guide our older adults to trusted systems and talk to the people in our lives that we know who are service providers, whether it be a medical, you know, a doctor, a nurse, a EMT, or, you know, a social service provider about how these older adults feel. Because once we're aware of because a lot of this is bias, right? Some of it is explicit, some of it might be informed by implicit. So people need to know, right? Because we can only address our implicit bias once we become aware of them. I do want to talk a little bit about some of our recommendations. Please go to the report, check out the rest of our findings. There are really some devastating things that we found, but really some things that really indicate we have more work to do with this population and more to learn. And so in the spirit of that, we came up with, what was it? I can't even see the number. I think it's 16 recommendations. I'm pretty sure that's how many. But they're in 5 categories. And those categories are kind of loosely defined as improving access. So this focuses on strengthening access to resources already available to older African Americans in Ohio. And part of that is also about helping identify trusted systems to deliver those as well, right? Because it's about trust with the population. Expanding access, right? And this focuses on enhancing the amount and quality of access older African Americans have to care more resources. Increasing inclusion. This responds to the isolation and lack of respect articulated by focus group participants. Is a call for including the voices and needs of older African Americans in decision making. Enhancing experiences refers to the need across agencies for improved understanding of and relationship to the older African American Ohioan community. And then strengthening place. And this refers to place-specific planning and policy decisions that can improve outcomes for older African Americans. And so we're going to talk about 4 recommendations today. And so the first is use of mapping tool. Mikyung showed you a little bit about how to use that tool. This is the tool that policymakers and service providers can use to identify literally neighborhoods, right, where you have acute needs for this population, right? And that can inform how you think about service delivery and policy, right? And then the other thing is too, this can be a tool, right? So at the Kerwin Institute, we aren't a proponent we aren't on the either or category when it comes to housing policy. We believe in housing choice and community redevelopment. So we've got recommendations in there addressing both. In terms of choice, you want to cite, you know, one of the biggest themes we had was safety. And some of the things people said about safety are downright terrifying, that we have older adults who are afraid to open their windows because someone might crawl in and steal things from them, right? That have shootings in the buildings they're living in parts of the state, right? So some of these safety things are really outrageous that we heard, right? We want to build older adult housing in neighborhoods that are safe. We also want to make sure they have access to transit, they have access to pharmacies, right, and grocery stores, and social service support broadly, but also activities, places for older adults to volunteer, senior centers, places like that, right? This tool can help identify higher opportunity areas, lower vulnerability areas, right? There's still some work to do though, right? We don't have transit lines on this because it's not available statewide, and it's like a big deal to build that data set, and it changes frequently as well, especially in the post-COVID era and during COVID. But this can help you identify places if you want to build additional older adult housing. And I'd also point out that the majority of older adults are suburbanized in this country. And then the other is listen, right? This was the first step in listening, these focus groups, right? But we strongly suggest that that the department and their partners conduct a statewide listening series. Because, you know, one thing that I will be, you know, these wonderful older people that we engaged in these 6 focus groups, we're so grateful that we came and asked them these questions, like all of them. They thanked us. They wanted us to come back. They're like, when are you coming back? Can we do this again? We'll do this next week. Like, are you free? I mean, because, and like they said, they feel overlooked, right? No one is asking them how to inform policies for them, right? And so ask them, right? And this is really, you got like these four purposes here, right? Learn what sources of information are trusted and how to enhance communication. Because in our communication theme, it's really about trusted sources of information. So we need to figure out how to better utilize those existing trusting networks while we're building new trust, right? It's a both and there, right? Understand the most acute barriers to thriving that they experience, one of which was also, that came out very strongly, right? Our children. We are worried about our children, especially our Black sons and grandsons. Like the stress of being Black in the United States of America literally weathers you, which is a term at the, you know, or you can call it racial battle fatigue, but there are literal health impacts, physically and, you know, mental and behaviorally, to experiencing racism and worrying about the threat of racism, right? And so this is really big for this population. Yes.
That is so true, because I just witnessed that Sunday, the lady in my church, she literally, no oxygen, poor oxygen, but she literally was getting sick growing up. And so I saw her the other day, had to go by and take her to the store, and she was sharing with me that she was so sick and so stressed out because of her granddaughter, her daughter had jumped on the 15-year-old, the 16-year-old daughter. And so to go ahead and go to state haven, but she was literally just worried about having to go back to that environment, and the fact that she didn't have a car to be able to take her to school, so she could keep her at her house. But that is really true, what you're saying, dissuade on that, because you never expect to bury your children, your grandchildren, you expect to go with that's what you expect. That's not happening, and so it does weigh in.
Yeah, and for older adults, they said that's the big concern, is like their family and those experiences that their family is having, right? And then understand what supports most needed to thrive and how to deliver them, and then really just gain insight into how to better meet the needs of older African-American Ohioans where they are. And that was just a big thing too, like meet us where we are. That's also one of our themes. But you can check them all out in the report. Oh yeah, there it is. Review existing lens through existing policies and programs through the lens of meeting older adults where they are. But you can check out the whole report online. If you want a presentation of this, please contact me. And we'll set it up. And now we'd like to open up for questions. We can have our other presenters come on up. And if you want to see a place, Mikyung, I'm sure, would be willing to pull up the map and give you more details on how to use that and turn those layers on and off.
I have a question.
Yeah.
As somebody who is Black American, also suffers with mental illness, are the hospitals and other organizations, along with police, working together to combat that fear? You know, it's really hard for somebody like me and other people like me to have the same comfort that somebody like you might have. If I'm getting robbed or something's happening or I'm scared, I can call the cops. Well, I have to worry about, if I call the cops in the middle of an episode, am I gonna die? And so even, you know, for me, I'm younger, so it's a lot easier to deal with, but the older you get, the more your mind goes. You have other issues on top of just being mentally ill. You have physical conditions as well. What are all of the agencies doing together to combat that? Because that's a really big fear right now. I know so many Black Americans that they won't call cops, they won't go to the doctor, because you go to the doctor, you tell the doctor your pain's at a 9. The doctor ignores you, you get frustrated and upset. The next thing you know, the police are called.
Yeah, I'm gonna kind of hand this one off to Adreana. I do want to quickly just say there are some municipalities that are looking at call diversion. And so Columbus has a pilot program. I think Worthington has one. Upper Arlington has a long-term one for older adults. Specifically, Worthington is starting it with older adults, but then plans on adding the mental and behavioral
calls, so this is a program where you call 911 and it's for, you know, a mental health issue, or it's an older adult that really doesn't have a medical emergency, but needs assistance, right? And maybe there are some chronic people who are calling, especially in some of our suburbs, you know, who we say are like asset rich and money poor. They got all their money in these houses that they don't want to leave their community, and their houses falling down around them, and they can't change the light bulb because it's too high, and they're calling the police for everything. So they're starting them from those places. We need them everywhere. And I don't know about coordination. I'm still ready to agree.
There's a lot of conversation, now that's happening within our systems. NAMI has a lot of those conversations going because they have been trained with, CIT, yes. And so we're engaging more, but like you're sharing, we really do need those voices at the table to talk specifically about those issues so that we can develop these, paths, pathways and interventions. So that our systems are working together with the community. A lot of times, you know, we do things outside of the voices. And so we develop these things, but we need also the residents at the table as well. I know Linda has an older adult program. If you want to respond to that, let me know.
Partnerships, I think, are the way we want to deal with folks. Well, the CIT training, I've been a part of that for a while, and I always, probably my critique of it will be, is it's one and done. You go through this for a week and now go out and be really good officers and do it the right way. Well, some do, some don't. Actually, some did, some don't before they went through that training. Hopefully we catch a couple of them, but I see our system of care now trying to mitigate in a way that they're putting mental health professionals in the groups. If there's a call through 911, we now have 988. So mobile crisis will go out. So instead of cops going out, there is less fear of these folks. Older adults, it's even a whole different thing. And what we do with that in terms of partnerships is we have wellness advocates where we coordinate all the connected care. So many folks go like here in older adult, we go to the podiatrist, we go to cardiologist, we go to their primary care doc. But none of them are really talking to each other in a way and making sure we have people that go with them and coordinate that kind of care and information. So it's looking at little best practices that are happening speckled all through our community. It needs to be, I think you bring God bless her. She keeps wanting to make this like a state initiative. And I'm like, no. It's yes,
It's kind of what we were just talking about with her. It's like everybody is trying to achieve the same goal, but you got 10 different people doing 10 different things, like, but nobody's talking to each other. And then we're confused on why the goal is 100%.
Right. In one of our first, I think our first study, we also used the term, we identified Central Ohio as, what was it? Systems, our system is rich, but our coordination is poor, right? We have a very good system of services for older adults. It's not very well coordinated. And I don't think we're doing a good job of getting information out to everyone who needs it, right? I think those who are connected are better at access.
It's because we had become so silent. We're all trying to be everything to everyone, and that's just not possible. When you can really tap into everybody's expertise.
Yeah.
In certain ways, so.
And I'm right now, doing a learning community with a lot of vulnerable populations. And some of them are these rich community of color, populations. We have an Asian in Action, I think that's in Summit County, that is doing tremendous work with immigrant and refugees that speak multiple languages and pushing them out and elevating them up has given a visibility to our systems broadly. So we have a silo kind of operation that we really do need to try to, come together and connect better. It's not really difficult, but people just don't do it. I was working with, AG, Attorney General, gave me a referral with a very complex older adult system case. And it was up in one of our rural areas, in Belmont County. They did not know that the answer was the agency that was next door to where they were. They are long-term care facility. I said, the answer is next door, go over and get the supervisor, because I've already called her to do the evaluation and the person that you have that's giving you all the brief. But there's really this kind of, delayed response of kind of connecting with other systems. So you're kind of in the isolated kind of functionality of your role. You don't even really think about it, but you need to try to reach out.
But if you think that comes from the fact that we are all decided, all these systems of care all come from a place of scarcity. And so you're all trying to do something in a way that you gotta garner as much money as you can. You partner with this, you made some money, and we can't afford to do that. So if we, I was just jumping into a more administrative role and watching all this happen. That's not healthy, but I understand where it's coming from. How change that?
Yeah, I think it's a leadership culture too, in terms of if we foster that kind of participatory, because I found this out during the learning community. If we foster that kind of participatory sharing and that richness that comes from our various purposes that do exist, we learn how to appreciate and value and share openly. And we develop our relationships with one another. We learn how to trust each other. And that's a big part. If I don't trust you, I ain't gonna work with you.
I mean, that's my biggest problem with working in cancer education and prevention, and we need to go get a mammogram or a colonoscopy. Well, why should I? The doctor's not gonna listen to me anyway.
Yeah.
You know, and working with that specific generation is definitely harder to be able to convince them or even help them understand that the times, while they might not be changing as fast as we would like it to, they are changing, you know?
I would also point out that system design kind of sets the parameters for how people can engage systems. And our systems are very kind of designed in a white supremacist way, right? And they're, like if we have public meetings, we use Robert's rules. And we've created systems that aren't necessarily accessible or don't necessarily feel accessible to everyone who maybe doesn't come from that middle class white background. Right? Because you have a lot of elders who come from that background who are super good at navigating the system and accessing services, using all the services they can, right? Because they're comfortable in that system. That's what they know, right? And we've done a very good job in this country of shutting out entire populations from kind of the knowledge and kind of access to the systems and navigate them well, right? Because we didn't let them participate in the past. And so how you structure the environment matters. And so that's just something else to think about too, in terms of how we want people to engage with our system, right? Are we using civic engagement theory, right? The strict father approach or the nurtured mother, right?
And one thing that I could add, in terms of mapping is, we talked about how different service providers might be working in silos. And then one thing that you could do is you could do what we call an asset mapping. You could place the dot on the map to show where those service providers are and see where it lacks in terms of, and if those areas that have higher vulnerability are lacking some of those services, those might be the areas that you could invest. Yeah, so that's something that you could.
Yeah, I think we have some online questions.
Now, the both pertaining to the map, I don't know.
Be loud.
Pull that slide up.
Yeah, be loud though also, as you ask.
So this is from Shan Yang. Thank you for your presentation. My question is, when looking at the spatial aspects of vulnerability, do existing local policies of reducing vulnerability of aging people matter in the analysis?
Yeah.
So the existing policies were not part of the
No.
data set. So they are not considered. It's really hard to quantify policy
Yeah.
and put it into a mapping tool like that. It's something actually we're talking about for our opportunity mapping. So it is not reflected in the map itself. The way you could do that is through dots.
Yeah.
You could have it, go
The
ahead.
thing
sorry.
that
I'll
I
stop.
just talked about, the asset mapping, you could just place the dots or place the areas where the policy has been implemented, depending on different policies, and look at how it made changes in terms of the vulnerability, or if it is making any changes in terms of vulnerability, and go from there to to measure or examine the effectiveness of policy.
Yeah, if someone wanted to do that with their geography and you like emailed us a request for like your county blown up, we could probably send you a higher resolution so that you can print a big one and actually do an exercise like that. We could do that, right? Yeah, we could send you a file to print.
Awesome. There's another one from Jessica Grimm about the vulnerability map. How much of the proximity to prisons plays a part in the numbers and density of vulnerability in locations outside urban areas? Since African Americans are imprisoned at a higher rate, it would make sense that areas around prisons might have a higher
Really good point.
concentration of vulnerable older adults.
Yeah, we didn't look at the data.
Now I wanna look at that now. Now I want to see where prisons are on that map.
Yeah, interesting.
Yeah. So when you were talking about the vulnerability mapping, is it only for the 3 counties that you studied though? Or
So this
do
is
you have a-
statewide. This is the first statewide older adult vulnerability online mapping tool we've ever created. And so that was the big aspect. So prior to this, it was only Franklin County. Now you can look at the whole state. One thing to keep in mind though, is with the way that we construct indices at the Kerwin Institute, if we are mapping Franklin County only, then you're looking at everything as relative to within the county. You're measuring each track against each other essentially. The state level, you can compare, you're almost comparing Columbus to Cincinnati, Cincinnati to Cleveland to Toledo and all of the other municipalities. And then that density map is really for those urban areas. And if if you're working in like southern Ohio, right? A lot of high vulnerability, high density areas, well, more high vulnerability and high prevalence, right? And in that part of the state, that prevalence map is really helpful in the rural portions of the state. Even though we don't have very large minority populations, particularly in southern Ohio, we do have larger Hispanic populations, like in portions of northwest Ohio, like kind of south of Toledo and stuff. So there could be some use for some agencies or social service providers.
This is vulnerability and prevalence.
Glennon, can you share out loud so that the audience online can hear how to access the mapping?
We haven't shared the link yet, so.
Yeah, we'll send it to Chief so that she can put it on the website.
Yes,
Okay,
along with the link to the reports.
I think the report's up there already, but the mapping tool needs to go up there.
okay. Good. So the website is,
Institute.osu.edu.
okay.
Any other questions? Yeah,
So we're working with a few of us on the smoking related project. And
smoking related projects.
basically we're trying to assess how the African American community, especially the smokers in the community, will perceive the Columbus flavor ban and the federal flavor ban. So menthol cigarettes will be banned.
Yep.
And then we're pretty sure that there is nothing supporting the ban. So it was perfect without any support for people to access services for cessation or like any support at this time. So nothing to like this would be very interesting for us because if we know that.
Oh, yeah, I'm ready.
You guys have data.
We have collected the data now. For the data,
Well, I mean, Mikyung is our spatial analyst, so she'd be like, why don't you guys can check.
Yes. We wanted to analyze it.
So I'm thinking that, so we know like where the smoking among the African American community move forward. And we know what type of station will be station clinic, access to primary care provider that will advise them to do, I think, the use of this station and things like this. It could be very helpful.
Is it a targeted intervention?
Yeah, exactly.
Yeah, I like that.
So this is the pilot now, we're doing it for the community-based engagement.
Have a lot of overlap with the high vulnerability against the area.
Well, still, if you look at overlay of African American, the overlay African American, you'll have, it's the same. All the maps in Central Ohio are the same map, guys.
Yeah, so that will be the discussion for, just to see if we can use this.
Get card. Again, favorite part of my.
Yes, here.
Yeah.
For the post, for the members, and the subject, and they seem to be to meet your aims.
Yeah,
Did you consider trying this?
so that is, the next step is our dissemination plan. I was actually gonna talk to Edgar about that today, if you want us to put that into them. Yes, that is, we do plan on disseminating it far and wide and going back to the place.
Yeah, the first thing that we have to make this community and this project is that we don't want you to go to them. We don't want you to go to the community. We like that they turn you back to the.
Yeah, oh yeah, that's not a practice we have at the current, we always go back.
Yeah, this is what we want.
Yeah. Yeah. Thank you.
Yes.
You guys are very wonderful.
Oh, excellent, yeah, we work with Daryl a lot. Daryl, yeah. Say again? Oh, he is, oh, excellent, yeah, Daryl's great. Yeah, Daryl's great.
So before we close, I just wanted to recognize Concord Counseling is doing one of our older adult faith-based projects. And I just wanted to open the floor and see if Edgar would like to share anything, who is one of our folks that works with Concord and is very engaged with the African American.
I'm encouraged by this presentation in this study because it's shedding light on something that needs to spotlights. I've enjoyed the program that I have done for a year and 9 months now, where not only have I been able to provide case management services, for the things that clients need, but I've also been able to provide engagement, enrichment, empowerment, help build a sense of community with seniors, who I think family members and providers think that, oh, my mother has houses, they're housing. Oh, my mother has a nurse that comes in. Oh, my mother has an aide that does things for me. They're fine. No, what is the missing puzzle? The most important, that's their voice, their family, their religion, and their sense of community, like they're talking about volunteering. Before I came into the community, it wasn't a community. It's independent housing, so they didn't have to become a community. But I think through the enrichment and the activities we brought and how they saw me helping and walking with the other people who needed help, it became a community where we could knock on the neighbor's door and ask for sugar. Or if we hadn't seen someone in a couple of days, hey, we checked on them not answering the door, we got to find out where they are. To caring what their community, the building looks like on the inside and the outside, and what we do together for fun. So it goes hand in hand. Engagement opens them to services because they trust somebody. And building trust is the most important thing. And I recently just got back from vacation, but I held my breath. I'm like, okay, it's been 2.5 weeks. Do they still trust me? Do they still think that I'm here for me? And they were.
Oh,
I've
they
never-
love it so much.
I feel like I need to go to a chiropractor and they just squeeze me so hard. Like, if you go anywhere, there's gonna be problems in this city. And I said, no, I promise you I will be here for a very, very long time. So that's what I've been working on. It's uplifting and it's very encouraging to see that when you give them a little bit of attention, they have so much more potential they can provide for the community. They are mentors to me. And out in the community, when I take them places, they're known. And people are like, oh, here comes the group from Chandler Island, yay. So, yeah, that's what I do. I really like to enjoy.
And they love them.
And I'm just seeing it from an administrator's perspective, but from the outside, I mean, not being too long, he takes them on tours everywhere. So they're going downtown, so he did a tour of Concord, so he brings them into the building, and they come just piling into my office, and they're looking at everything on my desk, and I'm going, this is amazing. I mean, so to see how they engage with each other, and how much they embrace this thing that they get to do. But it's beautiful, I honor this.
Yeah, well, you know, the folks at Akron all like social services, the folks at Chandler's Arms all love Edgar. Those were the two universal questions.
Did anybody else want to share anything in terms of older adult, related interventions or services that they do?
I don't know about older adults, but I would like to share flyers for our menthol ban study.
Yeah, we do.
It's their study, so they can explain it more, but I'll pass out, I've got 5. Yeah. Anybody can take them? Sure. For a student to apply. So basically, they're banning menthol in the state of Ohio in January. And so we are doing a survey. There's 2 parts. The first part is to gather attitudes towards the change or towards the ban. And then the second part is a biomedical where they're going to collect urine and nasal, right? Urine and nasal to see the effects on menthol. This is aimed specifically at the African American community. Anybody else?
And this program, this is already started, is that?
Yeah, it's already started.
Anyway, ban menthol.
No, the ban is going into effect January 1st.
Okay.
So they're banning menthol and it's late.
Okay, but I think in Texas it's banned currently. That's where Edgar's building is. Because they may, that's a whole different perspective. I don't know that for sure, but I have heard that. In Texas, we do have to go upgrade.
So is it in Bexley or are you just outside of Bexley? I was confused about that when we were.
First street outside of Texas.
Yeah, okay, that's what I thought, because like, I know, we use the street that is the dividing line for one of our neighborhood and street development tours. So that's why I was like, I thought it was outside of it. Yes,
I just wanted to share, I know someone mentioned 988, another really good resource. They're collecting that in this, they call a warm line. And I do it for 988, and a lot of the calls that they're not necessarily like emergency, we refer them to the warm line just so they have something to talk to. That's nice. Okay, this is like, it feels like really.
Is that the mental health online or the aging one?
We refer them to both, just a lot of times people call in, they just want somebody to back with.
Often the nice is once they develop that, there's a lot of times, because Warline goes through the peer center and a lot of times people will say, oh, and I'm usually volunteering here, I work this line on Thursdays, and they start calling on.
Thursdays, something else.
So they can have this one. So it's a wonderful, and this one's. Yes.
We can send that information out with our follow-up as well.
Wonderful.
thank you so much, everyone, for coming. We'll hang around if anyone has any additional questions.
Thank you, Glennon.
This is the name of my. Actually.
Fabulous. Actually help me on that last little paper.
Yeah.
I think so, yeah.
The university. Spring of 2024 on a